All right. Well, hello, everyone. Thanks for joining. Before we get started, I'm just going to do some brief introductions to the Wisconsin Institute for Healthy Aging and the Falls for Wisconsin Coalition. So, for those of you that don't know me, my name is Suzanne Morley. I'm a health promotion program coordinator with the Wisconsin Institute for Healthy Aging, or WIHA, and I'm glad to welcome you to this webinar. Just a few housekeeping pieces. This webinar is being recorded, and the recording and slides will be shared with everyone who registered within the next week or so. I just ask that you please remain muted during the presentation, but feel free to drop your questions in the chat throughout, and we will have some dedicated time towards the end of today's webinar for Q&A. So WIHA's mission is to improve the health and well-being of all people as we age. We do this by disseminating evidence-based programs throughout Wisconsin and nationally, and we also engage in public health strategies and initiatives. If you haven't heard of WIHA, you may have heard of one of our high-level evidence-based programs, and we have a couple of fall prevention programs, Stepping On and Pisando Fuerte. We are the North American license holder for those and others that help us age well. We also participate in health education on a variety of topics with our monthly Age Well series, webinar, and corresponding newsletter. And why we're all here today, we coordinate the Falls for Wisconsin Coalition, and we also coordinate the Wisconsin Coalition for Social Connection. Other initiatives that we're involved in include reframing aging and disability, brain health, and we also coordinate a biannual Healthy Aging Summit, which you can save the date for. We'll be holding in April of 2027 at the Jefferson Street Inn in Wausau. So the Falls for Wisconsin Coalition works to prevent falls as we age using a collective impact approach. Our coalition members come from aging and disability resource centers or ADRCs, healthcare providers and systems, emergency medical services, public health, local fall and injury prevention coalitions, and others. And we're focused on four main areas. So we engage in policy and systems change to improve the prevention of and response to falls. We raise awareness of the ways in which falls can be prevented as we age. We identify and share best practices and resources for implementation of programs and initiatives throughout the state. And we also collect and analyze fall-related data, including data about program intervention and impact, and state and county level fall injury, cost, and mortality data. So you can find more about the Falls for Wisconsin Coalition at our website, and I'll share a link in the chat if you're interested in staying involved after this webinar and joining our coalition. So with that, I'm glad to welcome Susie Ryer, who will share about how Aurora Healthcare integrated physical therapy into their emergency department to improve patient outcomes and prevent readmission after a fall. So I'll stop sharing.
Let's see if I can get my screen to come up here. All right. Well, thank you everyone for being here today. I'm really excited to share about the work that we've done. Looking at the list of participants, I know there's a lot of other great leaders in the PT and the ED space who are joining the call today too. And again, this is really a collective effort as we think about kind of one health system's journey as we looked at how to really address the issue of not just falls, but kind of improving care for older adults within our health system. So my name is Susie Ryer. I'm a physical therapist by clinical training. I'm also board certified in geriatrics. And I've been working at Advocate Health for, gosh, almost 20 years now. And in my role now, working with our senior services team to really improve the care of older adults across our health system through scaling some different models of care to best meet their needs. Also co-lead the Milwaukee County and the Waukesha County Falls Prevention Coalition and work with Suzanne and the rest of the team at Falls Free Wisconsin as well. So first, I'm going to have Suzanne kind of drop a poll for us, and it would just be helpful for me to kind of understand the settings that you're all working in and kind of the backgrounds of your roles. So if you could share kind of what your role is, what setting you may be working in, and then how familiar you are with the concept of having a physical therapist working in the emergency department. And then the third question is in the ED that you work in or in the EDs that you may have a relationship with, whether you're in EMS or in another part of your healthcare system, does your ED have a PT within their setting? So just going to take kind of a
60
look.
to 70% of participants that have answered, so we'll give it a little bit more time.
Great. And great. So a lot of you are coming from a base of some familiarity. About half of you are familiar with PT and ED. Um, and then unsure. Okay, well, good. By the end of today, you're going to know what questions to ask about if you have PT in your emergency departments, and if not, how to get that going. At least that's my hope. So, all right, great. All right, so I think we will go on to the next part here. And then one more poll question to get us started here. So I want you to think about what best describes what you see the role of physical therapists in the emergency department. So for those of you who are familiar with it or have had interactions, or even if you don't know, kind of take your best guesses as what you see that role is, and then we will hopefully kind of discuss that as we move through today, and have a chance to revisit that later on. So I see a lot on mobility and care transitions. Maybe a little bit focused on discharge equipment. All right, great. So I will kind of keep moving through here as we navigate on. So I'd like to start with, kind of framing this in the context of a patient or a client, an older adult that we might encounter, not just in the emergency department, but in any of the settings that we're working in. So Mary's a 74-year-old. She lives at home with her husband. Recently has had some issues with feeling unsteady, increasing difficulty with mobility. And as is unfortunately the case fairly often, we have someone who falls at home and she's just not able to get up. So as a result of that, EMS was called and they did decide to transport her to the emergency department. This is not the first time she's been to the ED or that she's had to call 911. It's happened a couple times. And the EMS providers are able to identify some things kind of on a quick scan. Her husband wasn't able to help her get up, and her house was pretty cluttered. So, as we move through the presentation today, I just ask you to keep Mary in mind, and we'll revisit her and her journey as we move along. So oftentimes, and I know when I started my journey of working, kind of in this space, maybe 10 years ago, and was working more with our emergency departments, we kind of get this thought about what our EDs look like. And I know, back in I'll age myself, but watching ED or ER, the TV show when I was in college, my vision of what emergency department was kind of like this, like a big trauma, lots of providers kind of in the space, all kind of diving in to work on these very high acuity, trauma care cases. But I think in reality, what we're starting to see in kind of the movement of our emergency departments is that our EDs look a little bit more like this. We know that the country is aging. We know that older adults are making up the most rapidly growing population in our emergency department. And not that older adults aren't coming in for traumas. And in fact, as we talk about falls, that certainly is a trauma. And those are oftentimes, very traumatic, and very impactful. But we see a growing older adult population that has very complex needs. And we've seen that grow over the last many years, and only continues to increase. And so the types of needs that they have really increase. And we also know that that kind of burden on the rest of our healthcare system is quite high, as there's about half of admissions from the emergency department are for older adults over the age of 65. So that kind of frames the population that we're thinking about, particularly in the context of coming in after a fall. I've used this slide for a long time. And again, as we think about somebody coming in after a fall, not uncommon that we might see an ankle fracture. So, here's two different patients that are coming into our emergency department. So we might have Mr. Jones and Mr. Smith. And for those of you who are probably better at imaging than I am, you could look at these and say there's some similarities in terms of the presentations of these individuals. But when we dive into Mr. Jones and look at, kind of how he presents his fall, his mechanism is probably very different, and what his discharge is going to look like is going to be very different. Versus Mr. Smith, who is obviously got some other needs. So as we look at these two, it's really important to think about that frame in terms of how we approach the care of these older adults who come into our emergency departments, because their discharge needs are going to be different, their follow-up care is going to be different, their ability to return home is going to be different, and so that really is the impetus for a lot of the work that we've been doing around centering kind of geriatric care in our emergency departments within our health system. So again, kind of framing up this idea of the complexity of older adults in the emergency department, they tend to have longer lengths of stay. They tend to be a population that requires more imaging and labs, 400% more likely to require social services. So we know that they have more complex needs. Any of you who work in patient satisfaction data know that this is a population that tends to be more dissatisfied with the care they get. And they're particularly vulnerable when they transition home. So I've often shared in presentations that, one visit to the emergency department is really kind of a traumatic and an inflection point visit for an older adult because when they go home, they're more likely to have functional decline. They're more likely to have revisits or rehospitalizations. They're more likely to, not really bounce back to where they were before. And so all this is really important as we think about older adults in the emergency department, because it's a moment in time where we have the opportunity to really address their needs, and their needs become much more than kind of the medical management piece as they come through. We also know that, why it's particularly important that we focus on what their care looks like in the emergency department is because they're not just staying and then going to the inpatient setting, but many of them are going home. Almost two-thirds of our older adults are actually going to discharge home from the ED. And again, knowing that they're at risk for poor outcomes, that they're more at risk for adverse health events in that month after discharge, it's really critical that we focus on what their care looks like while they're with us in our emergency departments. And so some of you are wondering where is the talk about falls? Because this is all about falls today. And we know that falls are the number one reason that older adults are treated in our emergency departments. So every 11 seconds, an older adult is treated in an emergency department. And in particular, we see that those high level of injuries we treat, also can lead to hospitalizations and deaths. And I think it's not surprising to anyone on this call that fall injuries are particularly costly. So we know that it's a huge impact on our health systems. And again, we see this as a highest risk presentation because a lot of these older adults who are coming in after falls, if it's not for something that would require, intervention, a lot of these patients are returning home. And again, that only magnifies the risk that that they encounter in terms of returning to the community. So now we shift and kind of think about what is value in the emergency department. And I use this because oftentimes as we're thinking about where our health systems are asking us to focus is on interventions, care that we can provide that's going to allow us to do things better. So in the emergency department, particularly, the focus is on things like cost effectiveness. So how do we ensure that we're doing most appropriate care in a cost effective way? Throughput, I know, is constantly a conversation in our emergency departments. How do we deliver the right care, but move people through quickly so that, as we have more patients coming in, that we're able to move them through to that next level of care. ED discharge, so being able to discharge patients home rather than having to admit and avoiding those admissions is really critical because, again, we know that there's issues with boarding. We know that there's issues with crowding in our inpatient settings. And so trying to ensure that we're moving patients to that next most appropriate level of care. Also, on the flip side, thinking about how do we prevent patients from coming back. So if a patient discharges home, we want to avoid having those revisits either to the emergency department or kind of a rehospitalization. And then as I touched on before, that idea of patient satisfaction. So understanding that, we want to make sure that patients are satisfied with the care they're receiving in our emergency departments, not only from the patient perspective, but from their caregivers and family perspective as well. So as we think about that, we can then kind of ask the question of where do physical therapists fit into this and how can we have an impact or how does that have an impact on things like cost effectiveness, effective care delivery, discharge, avoiding those readmissions. So what can the role of the PT and the ED look like? And I think many of you kind of touched on this a little earlier by saying, it's focused on care transitions. But really in our scope of practice as physical therapists, there's a wide variety of things that we can be involved in. So first and foremost is the idea of differential diagnosis. So when you've got a physical therapist in the emergency department that can help to reduce the need for unnecessary tests, can help to evaluate for most appropriate interventions. evaluating and treating. So if a patient comes in and there may be a musculoskeletal concern, there may be a gait and balance concern, these are all things that can be evaluated by a physical therapist, and then they can put together an appropriate intervention, and treatment plan during that emergency department stay, as well as, handing that off to that next care in the next care setting. Maximizing discharge disposition. So I think this is an area that, particularly in the ED, becomes very important for physical therapists to work in. So thinking about kind of what is that right next level of care, where should someone be discharging to? Do they need additional assistance? Are there additional resources they need? And then helping to facilitate some of those care transitions that occur. So again, as we think about the scope of physical therapy practice, there's a lot of areas that physical therapists can contribute to, particularly as we think about patients presenting after fall. So that might be looking at gait and balance, their strength, looking at footwear and foot impairments, doing a lot of patient education on how they interact with their environment. And then also thinking about things like patient function, safe mobility, ability to get up off the floor, and then again diving into some of the other factors that may be, predisposing to other risk factors for fall. So oftentimes, I think kind of the traditional role where people have thought of physical therapists is more in that kind of rehabilitation post-injury space. And so I think we also want to think about not just those patients who've come in after a fall, kind of how we can do secondary prevention for future falls and addressing their fall risk, but even for a broader older adult population who comes through our emergency departments, maybe for another reason, but who has some fall risk factors that could be impacted by interaction with a physical therapist. So thankfully, over the last, I'd say probably 10 to 15 years, we've really seen an uptick in, the literature around physical therapy in the ED, particularly as it relates to our older adult population. And again, this is not new. I think, we've got studies that go back as early as probably the 80s around physical therapists in the emergency department. And a lot of the early work was really focused on probably a younger population related to musculoskeletal disorders, low back pain, kind of a broader category of population. But I'll focus on a couple of newer studies that I think really speak to the impact as it relates to falls. The one that probably is the hallmark is the one from 2018 by Adrienne Lesser. And she looked at a large retrospective data analysis. They were looking at Medicare data. And what they found was that the odds of returning to the ED was 65% less for patients who received physical therapy in the emergency department after having had a ground level fall compared to those who didn't. And they looked at that kind of return rate at 30 days and 60 days and found that to be pretty comparable. So that was probably one of the kind of the sentinel studies that really spoke to the importance. I do think when she did that study, I think she found that of all the Medicare claims that they looked at, I think it was only about 10 or 15% at most of patients who received physical therapy in the ED. So there was a disconnect in the patients receiving this care, but really good outcomes, again, that lasted over a period of time in preventing those ED revisits. More recently, Liz Goldberg and her team did a study that was looking particularly at physical therapy and pharmacy intervention in the emergency department and found very replicable results in terms of having that PT consultation and that pharmacist review to prevent ED revisits after the patient's discharged home. So again, as we look at kind of the broader span of research, there's a lot of things that we can see from physical therapy intervention in the ED, decreasing ED length of stay, decreasing hospital admissions, reducing ED revisits, particularly as we think about our older adults, where we can limit some of the other things that we're doing. It not only cuts down on time, but it can also help with satisfaction. So things like reducing, unnecessary pharmaceuticals that are administered, imaging ordered, pain ratings. So again, trying to provide that kind of right level of care. And then also seeing, as I mentioned before, improving things like discharge planning and care transitions, helping to support patients who need to go directly into a rehab setting, and then improving that patient satisfaction. So there's several different models, I would say, that exist as we think about how to integrate a physical therapist into the emergency department. And I'll kind of speak about these. So, in our health system, kind of the original model that we used was a consultative model. So, our acute care physical therapists who are typically working in the inpatient setting would be consulted to come down to the emergency department. So an order would be put in, someone would be contacted, and they'd kind of make their way down. In that model, you don't have that kind of direct line of sight in the emergency department. And of course, there's kind of a long list of patients across a hospital that need to be prioritized. And so, the ED is just one of many care settings where the physical therapist is trying to interact with those patients. The next model is the embedded model. And I think from the early poll, we saw that many of you have this or are familiar with an embedded model. And that's where the PT is actually, the physical therapist is positioned in the emergency department. They're there throughout the course of their shift. They're really one with the rest of the emergency department team. So they're responding kind of just in time to the needs in the emergency department, seeing patients, getting those referrals, and access to patients. I think in our health system, again, depending on the size of our sites, we've seen a little bit more of a hybrid approach where we may have, an embedded, a PT position in the ED during certain high volume times of the day, and then the ability to kind of respond to consultation outside of those hours. Again, acknowledging the fact that the emergency department is a 24/7 site, and I don't know of anywhere yet in the country that has 24/7 PT. I think there's some places that have pretty great spans of hours across the day, but having to have some kind of options for a hybrid has been helpful for us. Other models that can exist is, again, if there's not the ability to have a PT in the ED, thinking about ways to connect those patients directly to outpatient after. Again, as I talk through some of the things related to this population, not always the most ideal not to see a physical therapist in the ED. Really, kind of best practice would be to have that. But in cases where you may have a smaller facility or not have that option, that can be another option. And I know places that are starting to look into the use of telehealth PT to do some of those consultations within the emergency department setting. So I will pop up this poll again. I don't know, Suzanne, if we already asked this one, but what kind of models have you seen within your hospital? And I think we asked that already, so we can keep on moving. So what are the things that make an EDPT unique? And again, I think, others on the call may have had experience with this as well, but it's a unique skill set. The ED is a really unique setting for a physical therapist to work in because you kind of have to be a master of everything. It kind of requires a superhero. So, first off, I think it's, a very function focused mindset. So particularly as we think about meeting the needs of older adults, a physical therapist in this setting is really going to be focused on what is needed, from a functional standpoint to help this person go back home, to provide support to make sure that they don't have another fall, to get them connected kind of with that next level of care, or resources. The patients who come into our EDs are complex, and I think many of you who are already working in the ED or have that experience can speak to that. But, it's not just about, mobility issues or medical issues, but it's also going to be what does their social support look like? What are the other challenges that they're navigating? Do they not necessarily have the ideal setting, or maybe the ideal setting isn't where they want to go? You might feel that they need to be in a higher level of care and assisted living, but they're not at a point where they're ready to make that transition. So, how do we kind of solve for those and navigate through some of those complex needs and challenges? Again, the types of patients we see in the ED have really evolved. And so when I talk to some of the physical therapists that work in our emergency departments, it's a mix. They're seeing older adults who have balance issues, frequent falls, but they're also seeing patients who come in with dizziness, vertigo, musculoskeletal issues. In most of our EDs, we're seeing, a wide variety of older adults and younger populations. And so that PT really needs to be able to meet the needs of that broader population. So it takes someone who's got a lot of those different skill sets. There's no I in ED, and there's ED is definitely a team sport. And so I think, one of the things I really like about engaging in our EDs is the fact that it is such a strong interdisciplinary environment. And so that PT who's working there really needs to be connected to the nurses, to the physicians, to the ED techs, to the entire team, because it's really about making that best decision for the patient, identifying things within their scope of practice to be able to really improve the overall outcome for the patient and to really help the whole team to kind of make the best decisions. Certainly mobility is key. I mean, a lot of what we're navigating, or PT is navigating, is how to safely mobilize a patient, help them to get the right resources or the equipment they need. But again, that's one piece. And then certainly, I think most importantly is that discharge planning. And sometimes it's not always about like what's the best discharge, but like what's the safest at this moment, what's good enough, like what's going to work for this patient, kind of in the purview of all the other complex needs that they're navigating. So for all of you who are on here, and it's a little hard for me to see right now, but for all of you who are on here who are working in your EDs, you're superheroes, and I think it really takes that unique skill set to be successful. So let's take a moment and kind of to walk through kind of three different scenarios of what a patient's interaction with PT and the ED might look like. So if we start with an older adult, again, coming in after a fall with maybe a mild or a relatively mild injury, what does that look like? So first, we've got a patient who comes in who did not have PT while they were in the ED. They came in with a knee injury as a result of their fall. So that could be Mary that we saw a little earlier. They're evaluated by the ED provider. Nothing, from imaging that really needs to be done. So they're given a narcotic pain med and they're sent home. They get an order for outpatient PT, but nobody schedules that before they leave the ED, so the patient doesn't follow up. That kind of hangs out there. Subsequently, they have another fall, they come back with an injury, and they return to the ED. Now they've got a more significant injury that requires a hospitalization. They're in the hospital and they end up with delirium. I think, as our culture is changing and evolving around the care of older adults, hopefully we're not seeing this as much. But again, I think something that we could see, as a natural progression, especially as we think about kind of the lack of care coordination that can often happen as someone's leaving the ED. Every patient feels like they're a little bit better once they get home, and so that need for outpatient PT feels a little less critical. In the next scenario, we have a PT who's available to come down to our ED. They do an evaluation of this older adult who's had a fall, but their focus is predominantly on their knee pain. So they may not dive a whole lot into function. They might provide a little bit of support around kind of what's going on with the knee. They end up sending the patient home with home physical therapy, but when they get home, the patient doesn't do particularly well. They end up having a revisit and then they end up having a hospitalization. And then what we would consider to be kind of the best case scenario is really focusing on not just kind of the injury at place, but kind of the whole picture of that older adult who's come into the emergency department. So looking at their needs, focusing on social supports, kind of what their function is, collaborating with that whole ED team to then make sure that we've got a better diagnosis and some discharge recommendations, maybe providing some additional supports in the home or looking at another care facility. So we'll take a moment and come back to Mary now. While she's in the ED, she does see a PT. They identify her gait instability, some high risk of fall. She does get issued a walker and she's trained in its safe mobility. And then beyond that, they start to have some conversations with her and her husband who's with her about her home fall risk, talking a little bit about her home environment, and within, the scope of practice of a PT, talking about how fluctuations in her blood sugars may change kind of how she's moving around, may increase her dizziness, her lightheadedness, and impact, some of her fall risk factors that they'd want to address. They help coordinate, with the team to get a home health PT referral, give her some additional safety recommendations, and then also connect her with other fall prevention resources in her community to help reduce her future fall risk. So as we think about, so that's the ideal situation. That's how we'd love to see, PTs become more engaged in the ED. So if you're not, doing this yet, what are some ways that you can get this started? So this is one of many resources that comes from our national APTA, American Physical Therapy Association. That was a kind of practical guide for putting physical therapists into the emergency department. This is just one of many resources that's out there. But I like this framework. So, first, if you're not doing this, like, where do you even begin? And I think, when we think about our journey, which I'll talk through in a moment, it's really asking those questions about, like, what's the greatest need or challenge in the emergency department? If bringing in a new resource like a physical therapist or an occupational therapist can meet an unmet need in the emergency department, like, everyone in the C-suites is going to go wild. So, some of the things that we can focus on are things like ED capacity and boarding. If we can move patients through more effectively, if we can help, provide prevent people from having to stay a long time to get admitted for a mobility assessment, that can really help to address that issue of capacity and boarding. What do our ED length of stays look like? If we have the ability to impact that and reduce that, or do we have high readmission or admission rates? Are we really struggling with care transitions and making those recommendations? Is that an area that bringing someone in could make the most sense? And then looking at kind of the diagnoses or the populations that are most commonly served in your emergency department. So, you know, I would say that just about any diagnosis, especially as we think about older adults, there's probably some alignment with the PT scope of practice. But, if you're seeing a high percentage of patients coming in after falls, musculoskeletal injuries, dizziness and vertigo, is that something we can really leverage as an opportunity to bring in that resource? And looking at how we can positively impact that patient experience through providing that PT consultation right there while they're in the ED. As I said before, the ED is definitely a team sport and a team environment. So, building relationships and strategic partnerships, I think, is probably the secret to really getting a new PT in the ED program off the ground. It needs to be something that the whole physician team, the ED nursing team is really bought in on, and that there's that sense of teamwork and kind of shared partnership, and shared goals. So again, if the primary focus in your emergency department right now is on decreasing length of stay or reducing boarding, where does that align with kind of what the goals of bringing, a new program like a physical therapist into the ED can be? Data and outcomes are our friends. I'll share some of our data and outcomes in just a minute, but really being able to tell the data story and how this changes outcomes. And then having a strategy to address the fact that PT is not usually a 24/7 resource. So, having pathways for making those referrals to home care, triaging patients, for safety, but then being able to make recommendations for follow-up care, outside of those hours when a PT would be in your ED. It takes some time to get this into place. So, some of the things that I always encourage people to think about is, PTs are mobile. We're adaptable as a profession, but you need a space, to function. You need a space to be visible to the rest of the team, and a way to kind of access the patients in the ED and be most positioned. And then I think, really making sure that where I've seen the most success is when PTs are really integrated as part of the ED team, and they're really considered just another member of that, tightly working group that really is focused on what's best for the patients. So I'll talk a little bit about our journey now in the last 15 minutes or so to integrate. So just for frame of reference, I know we have a lot of Advocate Health folks on the call, but we've been through a lot of evolutions as a health system over the last many years, but within Advocate Health Midwest or Wisconsin and Illinois divisions, we're made up of 25 hospitals and clinics with a large footprint over southeastern Wisconsin and kind of northeastern Illinois. Our hospitals vary from small rural community hospitals to large tertiary or large tertiary care centers like St. Luke's in Milwaukee or Christ Medical Center in Chicagoland area. And then we're part of a larger enterprise, which is Advocate Health, which now includes Atrium and Wake Forest, Wake Health in the North and South Carolina regions. So again, we're a large health system, and we've really been on this journey to move towards physical therapy in the ED as kind of our standard of care as part of particularly as part of our geriatric programming. So when we started this kind of idea of bringing physical therapists into the emergency department, I'd say it was really kind of driven. We had a lot of movement kind of going on at the same time, and it was really driven around kind of two distinct needs. So first, we had kind of meeting the specific needs of a single site. So some of our single sites were really focused on, how do we address kind of a population of younger adults with musculoskeletal injuries that could be addressed through physical therapy, evaluation, and treatment to address the issue of ED crowding. And so you'll see kind of on the left-hand side, there is kind of that population, that under 65 population, the types of things that we're bringing patients into our emergency departments, seeing a lot of musculoskeletal injuries. But then as a system, I think what we identified was a growing need to address the needs of our older adult population. So we've been on a large geriatric emergency department accreditation journey over the last 7 to 8 years. That's really focused on how do we improve care processes for older adults. And part of that is really looking at, what the needs of that population, which, as you can see, the number one reason is falls. And so that's really been an area of focus was how do we look at kind of best care pathways for fall prevention or addressing patients presenting after a fall. And that really was our catalyst for really growing PT in the emergency department. So I'll talk a little bit about kind of our falls and mobility protocol. This was something that, again, was required by the accrediting body, American College of Emergency Physicians, as part of some of our accreditation journeys, was to have a way of screening for and addressing patients presenting after a fall. So again, this protocol was really focused on who are those patients who are at high risk for future falls? Are there things we can do in our emergency department to care for these patients? And how can we connect them with follow-up care? So really a component that we built into this program was the need for early activation of PT evaluations for our older adults. And then using that as really the catalyst for then connecting to follow-up care. The next slide is a very kind of broad example of where we started. This has certainly evolved and in certain locations looks a little differently. So at its core, we really focused on our patients over the age of 65 who were presenting for a fall-related reason, largely focused on our patients coming from more independent settings who had been ambulatory at baseline. Our evaluation process involves some nurse screening using the timed up and go test. And then based on kind of the presentation of the patients, evaluating their orthostatic vital signs and looking at that piece. Based on those TUG scoring, we were using that as a way to triage or trigger PT evaluations for some of our highest risk patients in locations where we had a more limited resource. And then based on some of the findings there, we're able to make some recommendations for follow-up care, whether that was home care, outpatient physical therapy, and then also addressing some of the needs such as mobility devices. Where we've started to move as we've been able to move to a model where we have more PTs in our emergency departments is to really try to go to that direct referral process. So patients coming in after a fall would automatically see a physical therapist in the emergency department if they were discharging home to assist in that discharge planning. And try to evaluate them. And then outside of orders, like I said, we've got some different models that we can kind of rely on to connect those patients. I talked a little bit about collaboration earlier, in terms of kind of best practices, but I'd say that those were really the things that we focused on as well was, really aligning with our emergency department physicians. Our care management team in our EDs have really been tremendous to partner with and help to identify resources for patients and also help be kind of part of that discharge team with the physical therapist in terms of making recommendations. We really aligned with some of the system initiatives that were high for our health system. So trying to reduce our ED length of stay and our hospital admission rate, that's really gave us a lot of traction. Also looking at where we had some opportunities for revenue generation. So particularly focused on kind of the downstream revenue that could be associated with referrals to outpatient physical therapy after being seen in the ED. And then trying to get those patients connected with other follow-up care. Like I said, we really leveraged that falls procedure or that pathway as a way to gain buy-in for the need for physical therapy. And then once that kind of got off the ground, I think we saw a really rapid increase in sites saying we just need to have a PT here all the time. I think at this point, probably 2/3 of our emergency departments have some presence of physical therapists in their ED. And then, another piece that we've really looked at is leveraging data and metrics. So I don't see my colleague Chris on the call today, but a huge shout out to our team for the creation of some of the data dashboards that we use. This is just an example from one of our dashboards that allows us to look at the rates of PT consults that we're getting in our ED, if we're doing our TUG tests for patients after falls, what their ED return rates look like. So a lot of data that we're able to monitor to tell us if we're capturing the populations that we need to be serving. We've also been able to make some kind of ROI or some kind of financial arguments for the importance of physical therapists, kind of focusing on different diagnoses. We've been able to see percentages of patients we've been able to see, and particularly the number of patients that we're able to follow up with an outpatient as a way to kind of justify adding in additional FTEs into the ED, particularly focus on some of the downstream revenue that can be associated with that. We've also done a couple studies. One was a more informal kind of quality improvement project where we looked at older adults who came in through the ED for falls and just compared those who received a PT consult with those who did not. And we found, in that population that we focused on, a statistically significant reduction in their 30-day as well as their 72-hour return, very similar to that study I had shared previously. We also then wanted to look at some other studies or do a couple other studies that focused on not just PT in the ED, but what does that look like if we can help them to attend outpatient physical therapy? Identifying the fact that we can't always reach everyone within the ED setting. And again, with that study as well, we were able to find that patients who attended outpatient physical therapy, particularly in the 65 and older population, had statistically significant lower 30-day revisits if they attended that appointment. So again, looking at, and with that one, we were able to do some controlling for some other risk factors to help us to be able to get a little bit more, draw some more conclusions in terms of the impact that physical therapy had. So some of the lessons that we've learned on our journey, I think, to bring PT into our emergency department is that first of all, it's really important to have collaboration. Again, it's really the nurses, the providers, all coming together. I think knowing the stakeholders and understanding what's important. So in some of our facilities, it's really been, we want to address this complex issue of older adults. So, knowing if that's a priority, that's kind of where you can focus your programming on. Also knowing, kind of the patient population that you're serving. And I think that's where that data can really tell a compelling story. As I mentioned before, it's really important to have kind of the right PT in this setting and someone in particular who's able to address some of the complexity of the population and the variation of the population that's being seen. Any of us who have ever worked in the ED know to expect the unexpected because something is always changing. And it takes a little patience to build this kind of a program. But I think what we've found is that, sometimes you have to put that person there to start building the relationship and building the program. So if you build a PT in the ED program, patients will come, they will be happier, and as we see from some of the data, they won't come back again, and that's a good thing in our emergency departments. Wherever we can make PT practice really part of that ED workflow and team, it's essential. And using that data and those metrics to show the outcomes and the value, I think really helps to drive and not only drive, but sustain the program. And again, I think wherever we can kind of meet the big needs or the big challenges in our health system, that helps us to build the model that works. And then again, it's all about, showing value in the work we're doing. And I think particularly as it relates to PT, that's really where we have a great opportunity to provide a more value-based approach to care. I have a couple resources here, and I can certainly drop some of these in the chat, but a couple things that I found helpful as we've been kind of trying to create these business cases and stories. So with that, I will stop here a little early and make sure that I have some time for your questions.
Awesome. Thanks, Susie. I see one question in the chat so far. Have you been able to use Medicare waivers for ACO patients to use SNFs for select fall patients for more aggressive inpatient PT?
Yeah, that's a great question, Dr. Duthie. Yeah, definitely have been able to do that, I think, in some cases, especially during, especially during COVID when we had some more waiver opportunities, that was certainly an area that we were able to leverage a little bit more. I think where we can, we've been trying to do direct admissions from ED to skilled nursing, where we have that waiver and can avoid that 3-day admission rule. So I know at some of our hospitals, that was actually kind of the predominant reason that they were calling PTs to the ED was just for kind of expedited discharge and skilled nursing placement. And so that certainly can be an option.
Another question, how do you overcome OPPT wait lists for patients who are referred to outpatient PT after an ED visit?
Yeah, great question, Debbie. And I think that was one of the things that when we were building some of these programs, we did have to kind of look at was, what did we see as the anticipated downstream volumes and making sure that the sites we were working with had capacity. We've worked really hard with our kind of outpatient PT scheduling groups to prioritize our ED discharge patients, particularly the older adults, as kind of a high priority population to get in. So I know we have some aggressive targets within our outpatient physical therapy about how quickly we're able to get patients in for their first visit. I think another thing that's been really great is that, our PTs who work in our EDs oftentimes can schedule themselves. Like, they have the ability to schedule or they've got contacts to the schedulers at the outpatient clinic at their hospital or nearby. And so they'll work with the team to try to get those patients scheduled before they even leave the ED, which I think is a huge one satisfier. And secondly, can help to kind of expedite making sure the patient comes in. I think, again, the wait lists are a challenge, but that's really been an area that we've focused on as a priority population, much like, if someone had a hip replacement, you wouldn't want them to go, weeks without seeing PT or a knee replacement. And so kind of putting in that same high priority category.
Another question in the chat is part of the PTER patient care involve right care, right time education? If ED presentation should have been a different level of care, and how do you educate patients and perform the transition of care in that example?
Yeah, that's a great question. I might need a little bit more information on that. Michelle, I think certainly there are cases where patients, maybe the ED wasn't the right location that they could have used. Maybe they should have been seen in urgent care. Maybe it would have been better to follow up with primary care. Um, I'm not sure if that's what you're referring to, or if there was maybe another setting. I think, okay, yeah. So I think that's certainly part of the PT's role. I think that's a complex conversation that kind of the whole ED team needs to have as it relates to those pieces. But I think oftentimes, at least what I've seen is, those patients that a PT might be seeing, who's coming in. I think what we've encountered most often would be those patients who probably shouldn't be living independently anymore. They're frequently coming in for mobility or fall related concerns. And so, the conversation's probably a little less, right care, right location, but more like starting that conversation around like, is this the right, do you have all the resources you need? Is this the right care setting for you? Starting to maybe look at, some of those other supports that they need to start that conversation. But yeah, I think that's an important conversation and certainly one that PTs can be and are involved in. Other questions?
Well, I'm waiting for any more questions to come through. I'm just going to share a few upcoming learning opportunities that we have coming up. So we have a couple of webinars that are coming up, one within the next couple of weeks on June 9th related to the Steps to Safety program. So we'll have someone from the National Fire Protection Agency talking about the program. And then we have a couple examples of a health department and a fire department who are implementing the Steps to Safety program here in Wisconsin. And then on August 11th, we'll have a data webinar. So we had recently released some new fall-related data on our website. So we'll be sharing about that data and then also be sharing about some local examples, ways that the data is being used to prevent falls as well. And then we have our regularly scheduled Falls for Wisconsin quarterly collaborative meetings, our next one being on July 9th. And I'll drop the registration link for that in the chat. And then just keep an eye out. September is Falls Prevention Awareness Month. So we'll have additional resources coming for that soon. Well, Susie, I'm not seeing any additional questions in the chat. Oh, there's one more that came through. So do you provide community resources with your ERPT or make direct referrals back to those partners when appropriate outside of your system, i.e. community fall programs?
Yeah, absolutely. That's a great question. So, yeah, I think that's been something that we've really leaned into is
And
making
it's
sure
a
that
little
we.
hard to hear you.
Uh-oh.
I don't know
Is
what
that better?
happened. Not quite.
Let's try that. Any
That's better.
better? Okay.
Mhm.
Sorry about that. Yeah, I think that's a great question. So yeah, our PTs do make community resource referrals. They would do that, also in collaboration with, the case managers, depending what the referrals would be. I know in several of our EDs, they're using, we have some fall prevention toolkits that our coalitions have created that have, not only resources from CDC study, but also, the list of stepping on classes, other, community resources for fall prevention, supportive programs, things like that. And so they'll make those referrals as well. I think where we can, we really try to connect back to community programs that exist. We've also, really engaged with our community paramedic programs, particularly if patients aren't interested in, home care or home physical therapy, or they don't have those benefits. We have several really robust community paramedic programs or mobile integrated health programs that we've been able to connect with as well. So I think, depending on what the patient's needs are, at that point in their ED journey, those community fall programs can be really, really a nice option.
Leave it open here for maybe like 10 more seconds if there's any last minute questions. I'm not seeing any. Susie, do you have anything more to add before we wrap up?
No, I would just again, I thank you all for being here today. And again, I think this is I appreciate your interest in this. And again, I think it's a really exciting kind of area for PTs to be working in. I think can really have tremendous impact on our patients. So again, thank you for being here. Appreciate it.
Awesome. Thank you so much. Again, feel free to check out our website, fallsfreewi.org, to stay connected after this webinar. And I want to thank our 2026 Falls Free Wisconsin sponsor, UW Health, and funders, the Trillium Foundation and the Administration for Community Living. Again, this webinar is recorded and the recording will be sent out shortly. Thanks, everyone. Have a good rest of your day.